Hello everyone. Now I'll discuss question of neurology. Well, we have a 34-year-old man who come to you after several days of difficulty in walking. He also described some funny sensation in his feet. No skin rash, diarrhea, or joint pain. He has lower back pain for the last week due to lifting injury. While he was moving, he smokes one pack of cigarette a day, admits occasional IV drug abuse. He has not been sexually active for 3 months. His temperature is normal. BP is normal, pulse normal, respiratory rate normal, vitals are normal, to be more precise. Abdomen is soft, liver span is 8 centimeters, spleen is not palpable, cranial nerves are intact. Now, muscle strength is reduced in the lower extremities but well preserved in the upper extremities. Lower extremities sensation is also decreased. That means there is a motor and sensory deficit in the lower limb only. Mild hyperreflexia is noted bilaterally in the lower extremities. That points something toward the upper motor neuron disorder with weakness. Stroking of the sole of the feet elicit extension of the great toe. That means Babinski is positive. That really confirms that we are dealing with upper motor neuron lesion with paraplegia, with sensory loss also. Most likely diagnosis, which investigation you like to do, that it can really give us a clear-cut diagnosis, right? Well, in this case, the answer is MRI of the spine. Well, why this? The patient has sign and symptom of spinal cord compression. How can we say like this? Patient has complained of isolated symmetrical lower extremity weakness, including loss of sensation and upper motor neuron feature I told you, mild hyperreflexia, Babinski upgoing, plantar upgoing, upper motor neurons are there, and weakness without fasciculation, hyperreflexia, positive Babinski. They're all the feature of upper motor neuron lesion. Where fasciculation, if they are there, that indicate lower motor neuron lesion is there, but definitely they are absent. So one thing is very clear, we are dealing with upper motor neuron features. Well, when we are talking about upper motor neuron lesion, that really indicate that CNS is involved. Because symptoms are bilateral and present only in the lower extremity, the lesion can be localized to spinal cord. Okay. And the possible etiology is spinal cord compression, disc herniation, abscess, or malignancy are some of the important probable causes in this. But I have a question. You can stop the video, write down the answer. The question is, well, there is a bilateral upper motor neuron lesion which we think is a localized disease in the spinal cord. Now my question is, can some disease, some lesion in the brain can also have picture like this, so-called bilateral lower leg weakness with motor and sensory loss? Is it possible? If yes, where is the site of lesion? Stop the video, write down the answer. Yes, possibility is there. Well, again, go back to basic: brain, central sulcus, motor cortex, sensory cortex, leg area, and the head area. L for leg area, head area. And we have meninges. If the lesion develop in this particular area, maybe meningioma, it will cause pressure on these leg areas, motor areas, sensory area, and that can that can give a picture mimicking like spinal cord lesion. But in this case, there will be feature of raised ICP. Features shall be there in this patient. Okay. Well, the idea is to tell you that, of course, we can have possibility, but in this case, other than raised ICP, they will lead to headache, vomiting shall be there because of raised ICP. Well, though there's nothing like this in our patient, so we are most likely confined to spinal cord. And lesion could be some compressive. Compression can be done by disc herniation, some abscess and malignancy are the possibilities. Now, epidural abscess, even without fever, is a particular concern in this IV drug abuser. This one point, strongly, of course, fever is a strong indication. In fact, when we talk about epidural abscess, there are three things: fever, backache, and some compressive features are there. Okay, that is really to talk about epidural abscess. However, in this case, fever may not be very high also in some cases. Now, spinal cord compression is a medical emergency and must be evaluated immediately with MRI spine. If we do not, it's going to cause further compress the spinal cord. It can lead to permanent paraplegia. Point to be noted in this case, if we can take care in that well in time, we can save the patient leg completely. So that's why there is no delay. There should not be any delay. Do MRI immediately, diagnose and treat. Now let's look into other options. Electromyography is helpful in between nerve and muscle disease. Our is clear cut. We are dealing with upper motor neuron lesion. We are not dealing with nerve disease. We are not dealing with muscle disease. So electromyography has no role to play in this particular thing. CT of the brain, yes, we kept one pathology. This can happen. Okay, but patient abnormality is in the spinal cord. So we already ruled out there's no point in doing CT scan, but we know at the back of the mind, yes, there's something which can cause a picture mimicking like spinal cord lesion. But there is nothing to suggest about lesion in the brain, so we rule out CT scan of the brain. Lumbar puncture we do for any infective pathology, especially meningitis, or we can do in GuillainBarre syndrome or GBS syndrome. Okay, now a question for you. Suppose you do lumbar puncture in GBS syndrome. What finding you get in this? Stop the video, write down the answer. Answer is, there is proteins are raised, but cell count is normal. This is known as cytoalbumin dissociation. Okay. However, one of the most important indication of doing lumbar puncture is meningitis. Well, in meningitis we have fever, headache, neck rigidity, and there is nothing like suggestive of in this patient. So this is again a rule out. Okay. Well, now can it be GuillainBarre syndrome? No, because in GuillainBarre syndrome there is paraplegia, but that is flaccid type of paraplegia. It's a type of ascending type of paraplegia. Reflexes are diminished. But in our case, there are feature of upper motor neuron feature. This possibility ruled out. Endophomium test is diagnosed myasthenia gravis. It is a screening test, and it is a anticholinergic drug. It immediately, when it's a short-acting drug, it increases acetylcholine level and it improves the weakness in myasthenia gravis. Okay, but it's a muscle disease. In muscle disease, in myasthenia gravis, they have muscle weakness, but the reflexes, deep tendon reflexes are normal. Plantar is not upgoing, but in our case, DTR are in brisk and plantar upgoing, so this possibility ruled out. There is no role of endophomium test in this patient. Golden line to remember: spinal cord compression is characterized by sign and symptom of upper motor neuron dysfunction distal to the site of compression. They include weakness, hyperreflexia, and extensor plantar response, so-called upper motor neuron type of lesion. Cord compression is a medical emergency, require prompt diagnosis by spinal MRI and needs urgent treatment by antibiotic and surgical aspiration. Thank you very much.